Hey guys, welcome back. So this episode, we will be covering MS and neuro. For MS, we've been covering the cervical spine with TMD, temporal mandibular disorders. So let's start off with the cervical spine. A lot of the diagnoses, pathologies are very similar to the lumbar spine. Cervical stenosis, foraminal stenosis, and central stenosis. Central stenosis being narrowing of the canal where the spinal cord runs through, and if it's compressed, it can cause myelopathy, causing neurological deficits like gait, balance disturbances. And also you can have facet dysfunction, instability, headaches. We learned briefly about different types of headaches, primary, secondary. Primary headaches including migraines, tension type, cluster, and then secondary including cervicogenic. So the incidence of neck pain is actually pretty high. It is actually the second most common pain seen in outpatient clinics behind low back pain. Evidence shows that neck pain is associated with weak cervical flexors and extensors. So to strengthen those, for cervical flexor, you would lay on your back and perform a chin tuck while lifting your head off the mat 2 to 3 inches. And for cervical extensors, you will lie on your stomach and with your chest off the table and perform a retraction and hold it there to work on the extensors. Also, bad posture like protracted shoulder, which is due to like weak middle lower traps and weak serratus anterior. So strengthen those muscles can help with your posture, and which is also could be associated with the neck pain. So address posture for basically everything. Okay, and next I'm gonna talk about the cervical thrust manipulation. For this manipulation, the precautions, the contraindications, it's basically the same as the lumbar spine with a few more added. So basically, if you have instability, don't perform it, and if you have any red flags like osteoporosis, rheumatoid arthritis, recent surgery, and if you're experiencing like difficulty swallowing, dizziness, double vision, all that stuff. In the clip you're about to see, I performed it on Ryan, just in my room on my bed. You can actually do it probably anywhere as long as you have a pillow underneath, and when you do it, you take them to the correct position before manipulating. You can go wrong if the head is not positioned correctly into like extension or something. So definitely have to be careful with this one. Basically, first you assess it, of course, to see if they need the manipulation, if they're lacking movement, lacking motion, and then you would see which side they need it, and you would rotate away from the side, and then side bend toward that side to take the neck basically to end range. And when you feel like you're there, and then you perform the thrust, it's basically a twist, a quick flick of the wrist toward diagonal force toward the eye that's higher. And then here's Austin performing on Nick in a better environment.
Okay. Oh.
And then here's Nick being a clown.
Okay.
You killed him!
Alright, next let's talk about the TMD, temporal mandibular disorders. So the TMJ, the joint, is basically the temporal bone connecting the mandible, which is the jaw. So it's right here. And some common conditions associated with TMJ include anterior displaced disc with reduction, anterior displaced disc without reduction, inflammatory, subluxation, and myofascial pain disorder associated with the muscle pain like trigger points in the muscle. So basically there's a disc between the condyle and the eminence right here, and when you open your jaw, the condyle moves over the disc. And if it's anteriorly displaced, when you try to open your jaw, if you hear a sound, that would be called a reduction. And when you have a reduction, you'll hear a pop, and then you'll still be able to open your jaw. But if it's anteriorly displaced without reduction, that means there's no pop and you're kind of stuck there. That's without reduction, and you have less movement of the jaw. You cannot completely open your jaw. Some common interventions to treat it include joint mobilization, You can mobilize the mandible, soft tissue mobilization. You can massage the muscles around it, and also do modalities, ice, heat. So let's take a quick break and enjoy this quick time lapse of me playing tennis with some friends.
Everything changes.
Okay, so now let's move on to neuro. So neuro, we've been going over balance. The second module involves everything with balance. Once again, we learn a lot of outcome measures, basically a bunch of tests that assesses your balance, see what deficits you have, assesses your risk for fall. These tests are actually good objective measures that you can use to see how much the patient has improved. We give them the test from the very beginning and give it to them at the very end. And also they're good for writing goals. Let me see if I can remember some of these outcome measures because the test was a couple weeks back. So for sitting balance, you can use the fist, and for dynamic balance, you can use dynamic standing balance. You can use like the Berg balance scale or the Tenetti. And for balance with walking, you can use the DGI or the FGA. You can use the ABC to assess their confidence in balance, in their own balance, and MFES for addressing their fear of falls. So as for interventions, the most important thing is safety, making sure you're guarding the patient correctly. But at the same time, you have to push them outside of their limits of stability in order to work on their balance and challenge them. And also try to make it fun for the patients, be creative, like throw them the ball. And also under balance, we went over vestibular system. So the vestibular system deals with spatial orientation, gait stability, and postural stability. As PTs, we don't treat the attacks involved with vestibular pathologies. We just treat like the symptoms in between the attacks. So some common vestibular pathologies include neuritis, labyrinthitis, BPPV, bilateral vestibular loss, Meniere's, acoustic neuroma, perilymphatic fistula, and then central vestibular disorders like ICA-PICA syndrome. We learned about each pathology briefly, the duration of their vertigo, the dizziness, if it's position induced, if it's motion induced, and also if the pathologies have hearing loss or not. As for treatment, we learn about how to treat like gait stability using an index card with a letter in the middle, and then we would just stare at it and just move the head, staring at the letter or different things, working on stability. So that will be it for this video. I hope you guys enjoyed it, and thanks for watching.